When the World Health Organization declared COVID-19 a pandemic on Wednesday, March 11th, 2020, the Director General observed, quote, "This is the first pandemic caused by coronavirus." He added, if countries detect, test, treat, isolate, trace, and mobilize their people in the response, those with a handful of cases can prevent those cases becoming clusters, and those clusters becoming community transmission. As we approach the second anniversary of the pandemic, we continue to experience one of the most difficult times in the history of healthcare. While some of us have access to vaccines, too many do not. By allowing science and public health to be politicized, we face a situation where people with access to vaccines and the ability to follow simple rules refuse. Between vaccine inequity and hesitance, and because of politicization, the Delta, Gamma, and Omicron variants have caused surge after surge after surge. And as we begin 2022, David, I'm struck that many of our members are in the middle of another surge and just, doing everything they can to care for the millions of people with kidney diseases and just all the challenges we're having, particularly with dialysis facilities throughout the world. So just thought we'd start there on a somber note as we begin our next year of podcasts together.
Yes, and we are hearing a great deal from a lot of our members, and we are trying to stay on top of the issues that they're facing and do anything we can to coordinate where the government can step in and help. It is truly an amazing situation, and a lot of things are compiling. So we have places that don't have the ability to really increase their capacity to handle dialysis patients. And yet we've got more people in hospitals develop acute kidney injury from COVID, and it just becomes cyclical. And so while we're planning for the year, we are staying on top of this and really trying to figure out where we can help. But it is a difficult time for everybody in the country, and it's a difficult time for our members and the people they take care of. So we are all ears, and please do not hesitate to reach out to us.
Well, thanks, David. And really, just to echo what you said, that if any of our members are interested in contacting us, if there's anything we can do as an organization to help, please do not hesitate. I thought, future podcasts are obviously going to focus on the pandemic response, some of the challenges for our patient population and for our members, and particularly this cadre of trainees whose whole experience has been, during the pandemic, which I think is something we need to spend a little bit more time talking about. I thought for today, our audience would be most interested in getting a sense as to ASN's policy priorities for the year of the tiger. So as we enter this new year and we think of the priorities, maybe just sort of walking through each of them for a few minutes would be helpful.
That sounds like a great idea. And I just want to let the listeners know, if I get a little overly excited, it's because there's a lot of potential in this year. I haven't forgotten the somber messages the somber discussion we just had. But there's a lot to be excited about. And I'm hoping we can hit on it. Where do you want to start, Todd?
Well, it's interesting because as I think about the United for Kidney Health campaign and the priority of intervening earlier, part of the key there to being successful is identifying people at risk for kidney diseases. So why don't we talk about, from a policy perspective, what is our priority there?
Absolutely. One of the top priorities we have for everything going forward is based on this. And the reason why is because if we're going to try to take advantage of the changing landscape, and what I mean by that is things like the use of SGLT2 inhibitors and other new therapies, and basically really make a difference in the future of what it looks like to have CKD. If we're going to really do things like that, if we're really going to get ahead of the situation for those who do progress, who give them a chance to really think about things like home dialysis as opposed to just what happens when you crash into dialysis through the hospital emergency room. If we're going to really get ahead of that, we're going to have to identify those patients, and we're going to have to work with primary care. And nephrology and primary care are going to have to find a really good place to coexist on this one. And we're asking the United States Preventative Services Task Force to reinstate guidelines for screening people with CKD. and that we had guidelines that were removed around 2013, I believe. And those, and there's not been a lot of in interest, it seems, at USPSTF to go back and revisit this. And one of the reasons had been because they felt like it was expensive for very little that could be done to slow progression. And that's not true anymore. And our members know that, and they know there's a lot more options and tools in their toolbox. So we really have got to get U.S. Preventative Services Task Force back on track with screening for kidney disease. And no, it doesn't have to be every American. There are definitely ways to identify and to kind of prioritize who should be tested.
So as we think about just using this rubric of the United for Kidney Health campaign, that the second goal is around transforming transplantation and kidney transplantation. And I know there's a lot of priorities sort of in there. And just quickly, if you could give us a summary of some of the highlights as to what ASN will try to focus on this year in the transplant arena.
Well, as you've heard us, as we've been discussing so much internally, we are preparing our response to the request for information from CMS, for Centers for Medicare and Medicaid Services, regarding the entire transplant, ecosystem, they're calling it, and that has just so many pieces in it. It's kind of amazing what's in there. Our intention is to take our comments and make them a platform of advocacy for the year. So we're looking at things that need to be done in transplant that impact everything from the way in which the waiting list is managed and the way in which nephrologists access information about it, and transparency, and to really kind of see where we're going to go with the new metrics on OPO measurement for the Organ Procurement Organization measurements. And we're going to try to have to deal with the issues of discards and understanding why the rates of discards have risen as high as they have risen. And so there's going to be a tremendous amount there. I mean, it's been really interesting. When you talk about transplant care, as our people know, there's so much that has to be done to prepare a patient for transplant and to keep them healthy after a transplant. And that really requires a lot of different issues around kind of where's the transparency in the information? Where's the transparency on wait listing? Where's the transparency on which criteria will be used by which transplant center? We don't want to tie the hands of a transplant center. Some transplant centers may be much more successful at dealing with, let's say, transplant with an obese patient or a patient with HIV. And so we can't expect every transplant center to be the same, but they need to be transparent. People need to know where they're being listed and what the chances are for them to be transplanted there. And that's just really kind of key for getting our hands on transplant. Will be all about transparency. And that transparency means that there's going to need to be more coordination between HRSA, the Health Resources Services Administration, and CMS, because jurisdiction is divided out between them, and it's led to really siloed aspects of transplant. And one of the things that we are going to be doing this year is we are going to be asking for a secretary-level office of transplantation within the Department of Health and Human Services to coordinate those and perhaps even to evaluate whether or not the contracts on OPTN and others, if those need to be rethought through and actually just kind of in terms of how they are handled and what becomes the property of the government through those contracts and what remains with the contractor.
So, David, before we move to the next policy priority for 2022, can you give us the sort of 2-sentence explanation of the HHS, the Department of Health and Human Services request for information? So what's the purpose of this mechanism? How is it used? Why did the administration pursue these issues in this way?
There's been a lot of discussion, and it's about what's wrong with the transplant system and what's right with the transplant system. I don't want to be super negative here, because there's a lot of very successful transplants do occur in the United States, and that's great. Bottom line is this. I think after many, many years of looking at this issue, CMS is saying, particularly with the focus on equity right now, they are saying, if your patient who moves all the way to kidney failure and progression. If your patient is not being offered access to transplantation, then that should either be because there really has been a decision between the nephrologist and the patient that that's not the appropriate venue or the appropriate pathway for that patient. Okay. That's basically all that should occur. If that is not if we're not keep holding back a patient for that reason, then if your patient is, if that patient isn't being offered access and there's not an opportunity for them to move along in transplantation, then the system is failing. That is what CMS is saying, is that you need to be able to get people into either home dialysis treatment, and home therapies, or transplantation. If our only thing that we're offering them is a continuation of what we have, then we're failing them. We haven't innovated quality care. And that is nothing to do with, there are so many hundreds of thousands of people who have had their lives saved by in-center dialysis. And we are not in any way going to forget that. But the catch is the system has to offer them more than simply in-center home hemodialysis. And that's what CMS is saying. It's saying it's got to end up in a much stronger place than that. And we have got to get more people transplanted one way or the other.
And your point about equity is really important because, of course, the fourth priority within the United for Kidney Health campaign is achieve equity and eliminate disparities. And that issue really cuts through all of these priorities. And so each of these priorities have a component that are looking at equity and disparities and healthcare justice, which I think is really important. Let me circle back to the third priority within the United for Kidney Health campaign, which is accelerating innovation and expanding patient choice. And I know, to just start with the patient choice one, and then we could talk about innovation. I know there is a priority around home dialysis. So maybe let's talk about that for a moment, and then we could talk about the remaining priorities that relate to accelerating innovation.
Well, as we've been discussing repeatedly for a long time, and everyone in nephrology talks about, the disparities are tremendous. We were just talking about transplant, and the facts about transplant are not pretty in some ways, which is that if you are a person of color, you are far less likely to be worked up for a transplant. You're far less likely to be offered a high quality organ. There's just many things that you are far less likely to receive, and it represents substandard care. On home dialysis, and that modality choice that we all want to achieve, there is that as well. There are a lot of things about it, though, that are going to be hard to fix simply by just looking at this through a Health and Human Services lens or even CMS lens. So in order to get more equity in home dialysis, we have to make the situation for home dialysis really much more attainable for a lot of different people. And not everybody has both housing operations set up the way in which they really need them to, or has assistance. So we are looking at ways to achieve some level of home assistance for people who want to do home dialysis, whether it be temporarily from the beginning, or should they need to take a break from home dialysis and go back in center because let's say they're recovering from an illness and they're just not up to handling home dialysis themselves at home. So we really want to set up a system where there is an option for you to have coverage for someone to come into the home and assist you for a particular period of time, as well as dealing with remote patient monitoring being factored in. All of this is happening in the backdrop of a nursing shortage nationwide. So that means that we're going to have to take a look at everything in the home dialysis system for who provides what type of training to how we end up really making it possible. For example, do you allow, and I'm not saying that we decided to do this or not, but I'm saying, one of the conversations, do you allow some of the companies that provide dialysis, home dialysis and home dialysis products, do you allow them to also will the government allow them to provide some assistance in the home for anything that needs to be altered or adapted to, in the home for them to be able to do home dialysis? So you're kind of trying to figure out what the balance is going to be of who's going to provide what. But otherwise you just end up with people doing home dialysis who are in a position, housing wise and family and support wise, that is just not available to everyone. And that reinforces itself, particularly the more you get into income challenged communities. And so that's it. Just it's like most everything else in our society. The more money you make, the easier it is to make things happen. And some people have more assets and resources than others do.
Yeah, so just staying on this topic of patient access, and you'd mentioned home dialysis and innovation in home dialysis, but there's also the issue of bringing new drugs and devices to market. And I'm just curious if you could sort of walk us through that policy goal, which would be the fourth one that we've discussed today as we look to 2022.
Our listeners have probably heard us talk about the need to pay for innovation a great deal of times, a great many times, whether it's new drugs, new devices. The process has been started, and there's been an understanding and a system created to add money into the bundle for what goes into dialysis. But that's not the whole spectrum of CKD. We really need to have a more full-throated discussion with CMS, and we're trying to make that happen about the way in which the program is currently put together to pay for innovation in the kidney care space. And that may need some adjustments on Capitol Hill by Congress as well. But we need to have a pretty clear understanding of exactly what the time base is going to be, and will there be, particularly for anything that's in the bundle, will there be any new money afterwards? We've already seen what it takes if you've given additional pass-through dollars, and then you take those away at the end of a 2 or 3 year period, depending on which way we end up as policy going. You're really going to end up in a situation where all of a sudden something that was brought into the system will be just extracted. And so patients will have been given an option for a new technology or a new drug, and then have it kind of disappear from them in a matter of time, because the system isn't set up to really pay for that innovation long term. And that's just something that is really going to, I think, be very difficult and kind of weedsy to deal with, but we've got to deal with it. And everyone is telling us, and in the last year, how much our own members have really been brought into this discussion by advocacy efforts of companies and other groups to basically say, you guys have got to solely be behind innovative payments, because we're not going to get that. We're not going to get those changes that we need, and we're not going to see that innovation in kidney care if we don't.
But before we move to the next issue, I just want to sort of ask you to define three acronyms for us, and just give us a sense as to where they are as we move forward in 2022. The first is TPNIES or TPONES.
Well, TPNIES and TPONES for everyone are the same thing. They're just pronounced differently depending on which group you're sitting down talking about. But that is a transitional add-on payment for new devices and equipment within the ESRD bundle payments. So, and that's designed to pay for innovative devices that come along, or equipment that comes along. The first one that has been granted a status to receive these payments in the whole program is the new Tableau device for home dialysis from Outset Medical. So that was something that I think everyone was very encouraged to see. And there's a lot in that that we still need CMS to define in terms of what should be the guidance for systems that come along after that, for trying to hit the status that they need to hit within significant clinical improvement in order to get payment.
So then the next one, number 2, TDAPA.
TDAPA, if TPNIES is for equipment and devices, which it is, TDAPA is for drugs. And so that's a traditional add-on payment for new drugs. And the one that I think all of our people would know most significantly was the calciumetics that were brought into the bundle. And so that is the other side of this. Same issues that I just brought up. There needs to be more clarity about when new monies will come into the process, and where they'll go at the end of the period, the trial period for the add-on payments, so that as we talked about just now, so you don't have a lot of new products or drugs coming into the system, and then patients get them and then they're gone.
So the final one, which I always pronounce as MSIT, but I may not have that right.
That's right.
All right. What's that? Does it still exist? What's its future? What's going on there?
Poor little MSIT. I think it's kind of like a, who knows? It's the bad third movie of a trilogy that doesn't get made. It's kind of where we are right now. And MSIT was created to do what Tiffany's and TDAPA do, but it was designed to do it across medicine, across healthcare, and to take manufacturers, take new devices and really new technologies and give them an opportunity to come into the payment system with basically the approval from FDA paving the way for them to be paid within the CMS payment system. CMS argues that that's a really difficult thing because that they have their own statutory obligations towards determining payment. But MSIT was proposed at the end of the Trump administration, and then there was an interim final rule last spring, and that's a strange, different beast, an interim final rule, because it's supposed to be final, but it's interim, and it means they still have the ability to change things. So later in 2021, the Biden administration killed it completely, and that I think that we can expect that there will be a version of it, MSIT 2.0, even though there's no longer an MSIT 1.0, and trying to come up with something. But I think it will be structured significantly differently, or it'll be different significantly than what it was under the Trump administration proposal. And so that would be another type of payment system for innovation. But like we said, it wouldn't be just for kidney care or the bundle.
So the final policy priority for 2022, and I really think it cuts across all four priorities within the United for Kidney Health campaign: intervening earlier, transforming transplant, accelerating innovation, achieving equity, is really working with the National Institutes of Health, and not only in terms of general funding for medical research in the kidney arena, but more broadly around the third recommendation from the NKF ASN task force on reassessing the inclusion of race in diagnosing kidney diseases, where race was removed from the calculation or the estimation of GFR. So can you just walk us through what that priority, what the goal is there?
Well, ASN and NKF and a lot of people have spent a lot of time talking and thinking about what to do in this situation and how to basically remove the issue of race from the determination of, predicting, progressive kidney disease and kidney failure. And better than I, because you really were the staff person who kind of really led that effort between the two organizations. And I mean, it seems to me, I was going to ask you, it seems to me that implementation of it, particularly the side that the National Kidney Foundation is doing around the use of new criteria for laboratory testing, has moved rather rapidly, hasn't it?
Everyone within and outside the kidney community, including institutions in the labs, were waiting for these recommendations and how to have a unified position on this issue. And so things are moving quickly. And I think that the next piece, in addition to the implementation strategies and working with the labs, is this research agenda and this opportunity to really make good on commitments that the federal government made back in the mid-'80s with the Heckler Commission's final report, which we've talked about in the past in terms of ways to address and bring sort of ways to address issues around not only social determinants of health, but also improving care for underrepresented communities in the United States. So I think there's a lot that's going to happen over the next couple of years in this arena, both related to kidney diseases, but also to other chronic diseases that disproportionately affect minoritized communities.
Well, and so that, I mean, that really leaves us with a really big, important function for NIDDK, within NIH to fill. We are going to have really robust research on the changes to the EFGR from EGFR estimation, and also various other efforts to eliminate race and racial disparities from this side of this. And there needs to be research on how successful that is, what works the best. There just needs to be a really robust research effort that in the end of, helps us know, not in the end, because it's going to be ongoing forever, dealing with questions of the health of the body, but helps us really advance our understanding of what really does impact good analytic algorithms in healthcare and what doesn't. And so I think that that's a great opportunity. And we want to make sure that Congress is really supportive of putting funds into their budget that are specifically for that purpose.
So, David, thanks for summarizing the policy priorities for 2022. I hope your year is off to a good start. Recognize that many of our members and much of the patient community is really struggling right now. And, as an organization, we want to do everything we can to be helpful working with the broader community.
Absolutely. No doubt about it. And we are here. And we are, please reach out to us if there's things that you need to discuss, things that you might need some assistance with. We are doing our best to try to coordinate it. A lot of what needs to be done is actually happening on the state level, and that makes it a little bit more complicated in the fact that, organizing on the federal level is a little more direct. But this is something that we are here with our members for, and we hear everyone, and we will try to do our best to help however we can.
Great. Thank you, David.
Thank you.